everyone, and welcome to this episode of Adventures in Brain Injury. This episode is sponsored by Minnesota Functional Neurology and Chiropractic, a clinic in Minneapolis, Minnesota, treating concussions and TBIs, orthopedic rehabilitation, and the neurometabolic treatments for autoimmune and complex cases.
That's right. Dr. Jeremy Schmo is a very skilled practitioner in functional medicine and functional neurology. And you can find MN Functional Neurology and Chiropractic on the web at mnfunctionalneurology.com. Welcome to the 20th episode of the Adventures in Brain Injury podcast. My name is Cavin Ballister. I'm a severe traumatic brain injury survivor and creator of AdventuresInBrainInjury.com and FeedABrain.com. With me is my magnificent co-host and acquired brain injury survivor, Michelle Malmberg. What's happening, Michelle?
I am so excited to be here today with our new guest.
As am I. We're going to talk eyeballs and brains with Dr. Charles Shidlofsky.
He just tells me they're two of his favorite subjects. I think the three of us are going to be in some sort of, utopian dreamscape. It's going to be terrific.
Tell us a bit about Dr. Shidlofsky.
Oh, my pleasure. My pleasure. I think, let me start with this. Cavin, you are the best advocate for having someone consider their eyeballs and their brain axis. Is that proper? The eyeball brain axis, because ever since I've gotten to know you, it's like, have you researched the occipital lobe? What do you know about developmental optometry? And of course, I'm trying to explain to you that I'm still focused on the frontal lobe. Just give me a chance to get to the back of the brain, man. And you keep going on and on and on about developmental optometry and giving me little gems about my cranial nerves influencing my brain. I've really got to pay attention more to my eyes. And so here we are, finally speaking with one of your mentors, Dr. Charles Shidlofsky. And I think the two of you are, kind of in tandem. He grew up in New York and then moved down to Texas, did a little stint in Tennessee, picking up a few coveted degrees here and there. And you did some time in Colorado, then found New York, and then moved down to Texas. And so I'm thinking the two of you were destined to cross paths, whether you liked it or not, brain injuries aside. So let me just roll into the personal side of Dr. S. He's been so active in this neuro-developmental optometry field for most of his 29 years in practice. And I do have to mention that his dear wife, Sherry, has been supporting his work entirely that time. They've been married almost 30 years, or is it over 30 years now?
It's over 30 years now.
Oh, that's so beautiful. And we send our gratitude to Sherry because we know this is teamwork. And during that time, Dr. Shidlofsky has developed and integrated so many unique therapies, which have helped thousands of children who have struggled in school, big problems, due to vision problems seen in ADD, ADHD, the autism spectrum, sensory processing disorders, some of the classic vision problems such as eye teaming, eye movement skills, visual spatial skills, visual perception issues. And we're so pleased that you have expanded your work to include those of us with traumatic and acquired brain injuries, strokes, and other neurological processing problems. And we ought to note that in addition, Dr. Shidlofsky also works with several professional sports teams in the Dallas area, as well as his weekend athletes on developing vision skills. So it's important for all of us going to school, recovering from injuries, and those who want to optimize their vision perception for their game. And so currently, Dr. Shidlofsky is a clinical director for the Special Olympics Opening Eyes program, which thank you so much for giving that gift of sight and improving sight to so many people across so many different genres. Thank you. Thank you, Dr. Shidlofsky.
Oh, it's always my pleasure.
We have a whole load of questions for you, and let's start at the very beginning. And the reason that Cavin is so passionate about developmental optometry, and both of us had vision issues after we experienced our head trauma, and we want to know what happened. Why the eyes, Dr. Shidlofsky?
Well, if you think about it, the eyes are really just an extension of the brain.
Yes.
So when you've had any type of traumatic or acquired brain injury, a large percentage of people who have had that are going to have associated vision problems, and they can vary dramatically just depending on the location, as they always say.
Okay.
So, for instance, for yourself, where you had an injury to the frontal lobe, it will definitely affect executive function, but don't forget, vision system feeds executive function. So so that's really an important component. In Cavin's case, getting, a bump on the back of the head, it was going to affect his vision, visual acuity to accommodation to convergence, and a variety of other issues. So, location is a big importance of it. And don't forget, there's probably virtually almost every area of the brain is involved in vision in one way, shape, or form.
Really?
Absolutely. I was going to say, you were talking about the occipital lobe, and I'm like, Michelle, we're talking vision's affecting the frontal lobe. It's affecting everything. It's affecting it all,
Okay, so I want to know about that. Why is my temporal lobe involved in vision? Why is my parietal lobe involved in vision? Doctor.
They have all sorts of associations, of course. Your posterior parietal lobe is your mapping function. So it tells you where you are in space, how you can figure out how to move about space. So that's part of that parietal lobe. Frontal lobe obviously tells you what to do, how you do it, where you go. So, but as I said, the visual process feeds all that type of information. Temporal lobe has a lot to do with. Don't forget, your visual tracts go right along the temporal lobe. So if you have a temporal lobe injury, you'll quite often have a visual field defect.
Okay.
So temporal lobe, and obviously speech and language come from temporal lobe too, and vision impacts speech and language. So
when we talk about a visual field defect, that is not recognizing things on your peripheral vision or things outside of what's directly in front of you.
Yeah,
right.
It's more if you have a visual field defect, like let's say you've had a stroke and it affected. Affects that pathway that goes along your left temporal lobe back to your left occipital cortex. If you have that type of effect, you're going to expect a right visual field loss in both eyes. Okay, so you'll have lost the right side of both eyes and all of its associated function.
We have a right side in both eyes? Therefore, we have a left side in both eyes? Okay, doctor, please.
I mean, basically, if you close your right eye and look with your left eye, there's the left side, there's the right side. If you close your left eye, there's the left side, there's the right side. And when you put them together, if you have a visual field defect, is that what you said it was? Visual field defect? Then on your right side, then the right side of what you're seeing on both eyes is less recognized.
To put it simply, the way we're wired neurologically is if we have one eye. So if you have an injury to the right side of your brain, it's going to affect your left visual field. And if you have an injury to the left side of the brain, it's going to affect your right visual field. As I said, as if you only have one eye. More specifically, what happens is the fibers from the outside part of the retina, the temporal part of the retina that align your temples on your head, those fibers stay on the same side. They don't cross over.
Okay.
But the fibers on the nasal side, those cross over. So that's why you get half of a temporal and half of a nasal and half of a temporal and half of a nasal. So that would cause that type of visual field effect.
Wow.
I feel like we're probably, I'm like, whoa, here comes a waterfall. We got the fire hose going and we're trying to drink from it.
I'm going to leave it at that. Let's make it nice and simple.
Well, when you're picking up a couple of degrees and then a fellowship, there's a lot of information that this man can download to us. But you're right. You're right, Cavin.
Absolutely. And I really like it. The brain understands vision as if you have one eye for the most part.
That's
beautiful.
That's the binocular vision. The beauty of binocular vision.
So why do we have two eyes, do you think?
Well, why would you listen to music through two speakers? Robustness, right? It gives you robustness of sound, whereas with two eyes give you robustness of vision. It's giving you things, it gives things three dimensions.
Yeah.
Right, and it tells us where we are in space and time.
Of course.
It gives us a better representation of our surroundings, and so we can tell where we are and what's going on.
And so you can successfully hunt that saber-toothed tiger, Cavin.
There you go.
Saber-toothed or run from saber-toothed tigers.
Whichever you want to do. Depends if you're hungry or not.
That's a whole different story.
Okay, so Dr. Shidlofsky, I probably, after my neurosurgery, I ought to have been assessed by a very competent eye professional, and I wasn't. So if somebody has the opportunity to take care of their eye-brain axis, I've just made that up. It's going to be famous one day. So what do you recommend people do? Who do they look for? Do they look for an ophthalmologist, an optometrist, a developmental optometrist?
A neuro-ophthalmologist.
A neuro-ophthalmologist. Who are we looking for, and where do we find them?
And why?
Let me break it down, okay? I actually use the term in my office, neuro-developmental optometrist, because I do.
Excellent.
I do developmental vision, but I also do neurovision. And really, developmental vision is neuro, and neuro is developmental. Does that make sense? Because, as I said...
That's exactly what I say. I'm like, when we're doing neuro visual rehabilitation, we are rewiring, we are re-networking, we are redeveloping the brain. And so developmental and rehabilitation are very similar, and I think I talked about this in the last podcast, but, when it comes to nutrition and what I looked at for rehabbing my brain nutritionally, I was looking a lot at developmental nutrition because of exactly that. We are redeveloping the brain.
And
Right.
so then, how does Dr. S do this?
So, the way I look at it is a processing problem is a processing problem is a processing problem. Whether it's developmental or acquired really doesn't make that much difference. What we really need to understand is that there is a connection between the eye and the brain. The eye is really not a separate, it's a collection organ, if you will. It's collecting information, and the brain is processing that information. So you can't look at one without the other. And unfortunately, that's the medical community really hasn't picked up on that concept, that the eye and brain are really connected. You have an eyeball, is it healthy? You have another eyeball, is it healthy? But what is that? So you say you have two physically healthy eyeballs, but what does that mean to how you process information? Nothing.
Perfect. Yes, exactly.
Okay. So that's where someone like a neurodevelopmental optometrist or a neuro-optometrist can be helpful for you. If there is a structural anomaly going on with the eye, that's where a neuro-ophthalmologist might be more helpful for you.
Mm-hmm.
Okay.
So that's kind of how I break it down. Neuro-ophthalmology is more structural based.
Okay.
We look at structure as neuro-optometrists, but we really focus ourselves on function, and really also look at things like how do we do therapeutics to enhance that skill, a skill that's been lost, or bring back or rehabilitate that skill that's been lost.
Okay, so that's a
That's
really
beautiful.
good question. Yes, that is.
I know. Actually, let me chime in real quick. I talk about how we have the hardware, which is the eyeball. We want to see how the hardware is functioning, right? And if something's screwed up with the hardware, well, yeah, then that's not getting to the brain. That's like the top level, is making sure the hardware functions, right? But then how we process that information, that's the brain, and that's huge, right? So if the eyes are okay, cool, the eyes are okay. But now we need to talk about how the brain is processing the input that it's getting from the eyeballs. So ophthalmologist is looking at the structure of the eyeball, and a neuro-ophthalmologist is also looking at the structure of the eyeball. Where does the neuro play in with the neuro-ophthalmologist?
Well, what they're doing is they're looking at what is the function, or how is the structure of the optic nerve working? Is it working well? Is it doing what it's supposed to do? Is there, if they're also going to look at, is there a visual field defect? What effect does that have? But they're not going to give you a rehabilitative element to kind of help develop a skill to overcome that. That's where neuro-optometry jumps in. We're going to teach you the skill to overcome the defect. So, for instance, say you have a left visual field loss. Well, the neuro-ophthalmologist will say, you have a left visual field loss. And what we'll say is, this is how you scan to that lost visual field so that you're able to overcome that.
Okay.
That's beautiful. So rather than just diagnosing, you are actually coming through with solutions and therapeutics to improve somebody's function.
Right. And we may teach you how to scan to that missing visual field. We may put a prismatic lens on that other to help move that missing field over to your working field. There's all sorts of techniques we can utilize to improve that overall processing ability. So really what we're working is rehabilitating or reteaching you another route, another pathway so that you can utilize your vision system to its highest level of capacity.
So this is neuroplasticity. You're developing neuroplasticity.
Absolutely, 100%.
Okay, so then let me summarize, Cavin, if I may. So the input from the eyes, the visual system, integrates with the vestibular system, which is our balance, the proprioceptive system, which is our touch, auditory system, which is our hearing, which is why vision affects speech, and I'm tripping over my words, and the kinesthetic system, which is our movement. So, Dr. Shidlofsky, these are all big words, focusing on visual spatial skills, central peripheral integration, eye-hand coordination, the visual perceptual skills. I want you to download all that you can in less than an hour about how you can develop neuroplasticity for those of us who have deficits.
Before you do,
yes.
What I tell people when they are like the eye, the brain, like what's the huge deal of the eye? And I say, we have 12 cranial nerves, and those 12 cranial nerves innervate absolutely everything in your body. Everything, right? And so 4 of those 12 are dedicated to the visual system. 1/3, that is.
1/3.
4 out of 12, 1/3 is completely dedicated to your visual system.
So it's important. You're telling us it's important.
It's very important. If we're going to look at what innervates the visual system, that's actually 1/2 of your cranial nerves. But 1/3 is completely dedicated to them. That's huge. And then that's not even to mention the vestibular system, which is completely tied to the visual system.
Our balance.
And you were talking about the kinesthetic or movement, being able to affect our bodies to move in particular ways is obviously very tied to the visual system. That's how we play sports and do anything.
Right. So our balance, our touch, our hearing, our speech, our movement, it's all tied into these eyeballs and the processing of that input in the occipital lobe.
And the frontal and everywhere else.
Put it this way.
So, yes, go ahead.
I want to think about it this way. One of the big problems we see, for instance, in stroke patients is that they'll tend to ambulate or move to one side or the other, either to the right or to the left.
Ah, okay.
And quite often I'll go into the rehab center and they'll have a patient. This guy keeps bumping into the wall on the right side. And I can almost tell you right there what they've done is they've neurologically shifted their midline to that side. Okay, to that right side.
So what do you mean by neurologically shifted their midline?
In other words, they've adapted. They've created a maladaptation to their world, and they perceive everything. The middle of the world is to the right, so they're going to walk to the middle of their world, which is to the right. But eventually, you walk into a wall that way.
And by maladaptation, you mean we've realigned our perception of the world to a place where it's actually not.
Exactly correct. And so what do we have to do? Well, we have to realign. And that's one of the things we can utilize prism lenses for, in fact, is to realign that visual world and create the midline at their true midline so that they ambulate. So there's an example of how vision can affect kinesthetics. More specifically walking, but even had it in patients in wheelchairs. The wheelchairs will still go to the right if that's what they think the middle of the field is.
Of course.
So even a wheelchair-bound patient, if we can put a specially placed prismatic lens in there, oftentimes we can center their midline, and then just think about what happens to physical therapy then. Then when they're doing physical therapy, they're performing better. Their balance becomes better. Everything, their visual skills improve. So everything tends to improve when you just do that simple little application of prism for that particular type of patient.
Fascinating. And then, so Dr. Shidlofsky, it sounds to me like those deficits would be negative plasticity if you've realigned your midline after an injury such as a stroke. So is it possible?
Let me pause you real quick. So we haven't really talked about what negative plasticity is. Plasticity is awesome, but then plasticity wires the brain, right? And so you've heard the line, practice makes perfect. That's not really the case unless your practice is perfect.
Exactly. Perfect practice makes perfect.
That's what my karate instructor said years ago. And what the line is, practice makes permanence. And that's where negative plasticity is when we practice doing something the wrong way, because we are reinforcing those pathways to do something the wrong way. Or maladapt. Right?
Very well put. That's a very good explanation for it. So what we end up doing, though, when we use lenses like this, is we then do positive plasticity, if you want to call it that.
Okay.
And we retrain the brain to say, okay, here's your center of your world, and this is how. And now we can utilize this newly developed, or breaking the old bad habit, developing the new good habit, if you will.
Yes.
This new central plasticity, so that and then it starts affecting, as I said, it starts affecting balance and gait and things like that are so important to the patient who's had a brain injury.
And so then, Dr. Shidlofsky, is there the possibility of removing these special lenses so that eventually the patient could go back to a regular lens, or perhaps no glasses at all?
Oh, absolutely. In fact, I actually use the term neurotherapeutic lenses. These are neurotherapeutic. Therapy meaning you're going to treat something so that you've reached a resolution point. Okay.
Wow.
So once you've retrained the brain, once you've recreated the plasticity for central processing like that, then you can remove the glasses and you will stay right there in central.
Oh my gosh, how exciting that must be when you see a patient who can remove their glasses and operate perfectly as they were before the injury or accident or stroke. Oh my gosh, that's exciting. How does that feel for you to see your work?
Oh, I mean, to me, every day is a new adventure, and every day is a lot of fun. As I said, I've been doing this 29 years, and every day I look forward to coming to work every day and doing what I do, because it's an exciting place to be, and it's exciting to help people who really need the help, and that's what drives me every day.
It's an adventure, baby.
It is.
I love it. Yeah.
I think I'd add, the fact that one of the things that we along this adventure that I've had is I've realized that, number one, while we have a lot of answers to help the visual system, but we don't have all the answers. And that's where, it's been one of the nicest things is been able to work with other types of practitioners along the way. And I think that is that's been really, really exciting to work with all different types of people in the medical field to really treat the whole patient. Okay, while we're treating the visual system in the brain, the real goal is to treat the whole patient, and that's where, as I said, that's what drives me. Also, is just the excitement of working with other practitioners, learning from them, and then taking a piece of what I learned from them and integrating it into what I do.
So who are these wonderful people, these lovely souls who have this open mind, who are walking with you on this journey? When I explain functional neurology and now neuro-developmental optometry, people look at me, give me the little head cock to the side, and this is all new. So please tell me, who's walking this path with you?
Well, from a pure beginning of the rehab start, the people I worked with the most were really occupational therapy and physical therapy. Physical medicine has been a real big supporter of what we do. Or I guess they call it physiatry. They're very big supporters of what we do. As I said, speech pathology, neuropsychology, psychiatry to a small degree, pediatricians to a small degree, and then, as you said, there are some other fields like functional neurology, where I've had a great relationship with a functional neurologist for over 10 years, and we work together on many of these cases. And in fact, I had the opportunity this year to lecture at one of their international meeting of functional neurology and kind of share with them what we do in vision work. So that's really been an exciting process that we're trying to develop even further.
And as you know, I am a huge proponent of synergistic therapies, or a belief that the effect of therapies done together is greater than the sum of them done alone.
I would agree 100%.
Yeah, meaning that we can do vision therapy all day, and we'll get a little better. If we do physical therapy all day, we'll get a little better. When we put those together, we get a lot better, like more than just how much better we get from each of them. And so I'm really big believer in combining these tools and using them to optimize our recovery and our function.
Well, I like to say there's many pieces to the sensory puzzle. Okay, that's in fact, when you walk in my office, I have a sculpture of a puzzle piece that's up on the wall, and really because that's really the theme. Whether I'm dealing with autism, or ADD, or a patient with a traumatic or an acquired brain injury, that's my recognition that the visual system, while it's very, very important, is part of a bigger human body. So the synergistic element.
Just so you know, I have a huge smile on my face when you're saying that.
I can see you having that smile. And I tell people I don't pretend to have all the answers. I don't have all the answers, and that's really the way perhaps a medical ego should be.
Yes.
Work hard, stay humble, and you are right on with your medical ego.
Oh,
Please
thank
go
you.
on.
Yeah.
I all of a sudden I have so much more respect for. I already did, and now it's just deeper. Thank you for that. Go on, please go on.
Well, as I said, I think the problem is some people think they have all the answers, and nobody has all the answers. So that's really what I found out a long time ago, is that I need these other practitioners to work with me to help me understand the patient as a whole. And so sometimes what'll happen is I'll go through and I'll start treating a patient, and I'll recognize, this problem is bigger than just the eyes. And I said, they're having trouble processing information, auditory or tactily, or they're having just trouble with kind of a confluence of where they are in space. And so that's where I go to these other practitioners and say, hey, look, I'm going to send this patient over to you. We're doing this, and this. But they need help in this area, and so that is, and then we'll kind of confer about, after they do an evaluation, we'll confer about the patient and say, hey, how do we work our pieces so that they work together and make them more synergistic to help the patient out in the greatest way possible. So that's really, as I've really been my approach for many, many years now. I even going back to when I learned about the vestibular system, I learned it not from optometrists. I learned it from a neuro-otologist, a neurologist ENT, who taught me all about the vestibular system, and I taught him about the visual system, and we got that information. And that
neuro-otologist, ENT, otologist,
neuro-otologist,
and that's ear, nose, throat doctor.
Yep.
Okay.
Wow. You know,
pairing together the vestibular system, and you were teaching them about the visual system to pair with the sinuses and the vestibular system.
Exactly. So, you have to take every opportunity to learn and take in more information, and try to have a better, clearer understanding. The brain is so complex. I mean, and no two brains are exactly alike, which makes it even more interesting. But it's so complex, and there's so many elements to it that, as I said, nobody has all the answers. Nobody could possibly have all the answers. And really, I think we've learned so much about the brain really in the last 10 years. I mean, the concept of neuroplasticity when I started didn't even exist. No one talked about it. I talked about it but I didn't call it neuroplasticity because I didn't have a name for it.
I just wanted to comment about the medical ego, and you said, I don't know it all. And that's perfect, right? Like, I actually wrote a New Year's post, how I talked about my New Year's resolution was to be more badass than I was the year before. It's the same resolution I've had for years.
I could see that coming from you.
I concur.
Absolutely. But my definition of what a badass is has changed over the years, right?
Okay. Sure.
And so at that point, I'm like, a badass is someone who knows that they don't know it all, and knows that anyone who thinks they do doesn't even know enough to know that they don't know it all. You know what I mean?
I'm right there with you.
So I really appreciate that aspect of, like, the arrogance is hindering medicine, You recognize that everybody's brain and body, brain especially, is different. And what I say is the subtleties in the differences of the brain profoundly affect function and affect personality and affect reaction, and it affects everything in huge ways, right? So, I just wanted to reiterate that I love what you're saying with taking the ego out of medicine and being in a place of curiosity rather than in a place of arrogance or knowing it all.
I also think, I've said this frequently to my patients, the owner of the brain gets a little bit of say in the whole process.
Thank you.
Thank you. Yes. And so you were taking your humility and your knowledge, and you didn't even have a name for what you were diving into, exploring, and you're blazing this path and bringing a few people along with you. So you met up with this neuro-ENT, and you're teaching each other. And where did this lead?
Well, for a time period, I actually went down to his office to see patients. He was actually not far from Cavin in Austin, and I said, then we just developed. We cross-referred to patients over the years, but that was just one step in the trail. As I said. At the same time, I started working with a lot of occupational and physical therapists, and I would do the same with them. I said I keep reiterating that point. And then 10 years ago, I met Dr. David Rosenthal, who's the functional neurologist I worked with for that long. And now I've made contacts with so many more functional neurologists through my lecture last year at the functional neurology meeting. In fact, next week I'll be up in Denver speaking at the Revive Clinic in Denver, and doing a lecture about vision and then how we can work with functional neurology better. So I'm really kind of also now getting out and talking about how do you develop relationships within other fields that will make what we do even more potent and even stronger.
I'm so thrilled to hear that you're going to be speaking to so many integrative experts at Revive. And when we start delivering care like this to so many people, and as you say, looking at that whole puzzle, treating that patient as a whole being with multiple systems, all influencing one another, I mean, the results are going to be spectacular. We already know this. Now, my question is, how do we take this to more people?
Well, certainly, Cavin's out there yelling and screaming from his perch,
Yes.
And that's certainly a great way. Social media is a great way to get the word out. I think it can be good and bad, but truthfully, social media has been a great way to get the word out. Having people tell their stories is a great way to get the word out. And then from my perspective, the other thing that I do is I teach other optometrists how to do this.
Thank you.
So in my office for 20 years now, I've been taking fourth-year optometry students and kind of enlightening them, getting them out of that school mode and really showing them a different world that exists out there if they're so interested. And then as of about 3 years ago, I started doing a 1-year private practice residency. So I have one person who's already an optometrist that comes and spends a year in my practice, and
Wow.
we teach and learn together, and then hopefully they will go out into the world and continue doing it, and continue to learn and do it the way I did it. So I think so replicating yourself becomes really important. And of course we have organizations out there like the Neuro-Optometric Rehabilitation Association, which has an important place in trying to provide education for optometrists, and College of Optometry and Vision Development for doing the same, optometric extension program. We're all trying to educate people to better serve, better train optometrists to jump into this field and be involved in this field. And the more people like myself out there who are doing it, the more the word's going to get out to the rehabilitation community that these type of services exist. The biggest problem I had at the beginning is I had one rehab center that came to me because they worked with an optometrist. They had a sister center in California that worked with an optometrist, and they wanted to work with me, and I started doing the work for them, not having really done it before. And what ends up happening is therapists leave that place, they go to another facility, and they tell them about me, and they say, oh, we had a great vision program. And then they call me. And so it developed, but it's just myself. So then what ends up happening is we need more people doing this, more optometrists devoting their time and career to doing this. So that's why it's so important for me to train the next generation. And I started last year doing teaching a 2-day course for optometrists on brain injury to kind of get them up to par, get them ready to learn and be part of this growing optometric community that serves this population.
Isn't that something? So I'm in Canada, Calgary, Canada, in Alberta, which is along the Rockies edge, the eastern edge of the Rocky Mountains, and there are a couple of, maybe even a few functional neurologists who have either trained in the U.S. and then returned to their hometown, Calgary, or some of the locals who are heading down to the United States right now to pursue, training in functional neurology. And so I'm excited when you're telling me about all the effort you're putting in to teach the next generation. I was just getting shivers running through my body, and short of cloning you, we do have to take and respect your time. So would you welcome students from other countries such as Canada or Europe? I mean, how do we, I just want to bring you up here and have you teach. I'm so excited, and I wish we could just spread this information, this knowledge, and this potential rehabilitation to everyone.
Well, first of all, I love Canada. It's, I've been there many times, and I will tell you, there's a very active and growing group of optometrists in Canada that are doing this and teaching this now too. Obviously, coming up to Canada and teaching a course in the future is one of my goals, and hopefully we'll accomplish that in the next year or so. But there is a very active group. There's actually a new group that did their first meeting last year called COVTNR, College of Optometry and Vision Therapy and Rehabilitation. That's a Canadian organization, and they're teaching optometrists how to do this type of care. And I'm real excited. They've really developed a very, very outstanding program now, and they're having their second meeting, I think, in Montreal this summer. I think it's a great step forward for Canadian citizens to have more and more optometrists involved in this type of care.
Well, it's essential. I mean, the way you describe, the integration of the specialties, which is absolutely critical. We've got to break down these silos, these medical silo models, and create that integrative, cooperative approach to rehabilitation, no matter what the diagnosis is. But I'm having struggled so much the last 6 years after my own 2 acquired brain injuries, one the brain tumor and then the second an infectious brain injury. I'm so excited about the future, so that patients like myself and like Cavin, they have the options presented to them in the patient package. Here is what is available to you, versus us trying to dig up and resource and fundraise and go into debt to try and pursue these specialties that are at this point in Canada, so far away.
Oh, absolutely, and it's exciting to see it. But you know what? Even in Canada, I know, because I've seen some articles on the websites, there's a lot of discussion about things like concussion in sports. Obviously hockey being a big sport in Canada.
Yes.
Concussions are a major concern. Football, but women's soccer and men's soccer is also a big area of issue with concussions. Yes. And so the discussion about concussions is getting very, very loud right now. And that's only going to serve the community more and more. And this is why we have to train more people to be able to co-manage these situations. I'll give you an example. I had a professional soccer player I was working with this summer, and we were doing he had done some PT work, and then he came to my office, and we were doing some vision work with him. And I called my friend Dr. Rosenthal. I said, why don't you come to my office on Friday and let's work with this patient together. So he actually came to my office, and we worked with the patient, and his input to that therapy process was so valuable. It really helped that patient really accelerate their care.
Phenomenal.
Yeah, beautiful.
So is it going to be possible to have these athletes and these sports organizations even consider outlawing or discouraging heading of the ball in soccer? Or, I mean, hockey, as you know, it's a very contentious issue. And quite frankly, I'm not impressed at all with professional hockey because there's so much body contact, and it's really, really violent at times. I mean, can we impress upon these organizations to reassess how their players are engaging in the sport and maybe making some changes so that we're not doing all this cleanup and sending people to specialist doctors to retrain and improve their brain function when it actually could have been prevented?
Certainly, I think it's being looked at much more so for instance, in the National Hockey League, developing headgear that is going to be better, and same thing in the National Football League. Obviously, the movie Concussion came out a few years ago, and that really spread the light on it. And I think the protocols for concussion are getting a little bit more stringent. But still in all, I'm actually dealing with a hockey player right now who had a concussion, and the coach really just wants him back in the game, and so there's that tug of war that exists between what the coach wants and what is best and most practical for that particular athlete.
Mm-hmm.
May I ask one more question, Dr. Shidlofsky?
Absolutely.
We got time for one more?
I got time for one more.
So we were touching on, and a lot of your work focuses on the pediatric population with improving the ability to focus and see the chalkboard, the smartboard, and other classroom tools. What about the screen time and the effect of all of these screens of blue light on these young developing brains? Could you give us more information about how to protect them and how to support them?
Well, screen time is just a way of life these days. It's unfortunately become the virtual babysitter, and that's just a fact of life. I mean, I can't believe it. I walk into an exam room some days, and I have a 1.5-year-old playing on the iPad, while I'm doing the sister's examination. But it is a way of life, and so. I think parents really need to think about limiting screen time to some degree, or do it in smaller segments of time. For instance, I think 20-25 minutes should be maximum, and then let's take it away for a little while and do something else. I think the problem we have today, and why we're seeing so many more of these learning-related vision problems, is the lack of three-dimensionality in their worlds. Okay.
Oh, wow. You
used to go out and run and fall and climb fences and things like that. And believe it or not, there was a risk of getting hurt, but you also developed more coordination and more motor coordination and more visual coordination because of it. Okay, and now we just don't have that. They much rather be in front of the television, in front of the video games, or in front of a device. And so I think this loss of three-dimensionality has been kind of what has triggered so much more of these visual processing problems over the long term. And then taking it to the next step is now we have this issue of blue light, which has been researched heavily over the last few years. And blue light has been determined to affect sleep patterns or release of hormones that affect sleep, primarily from the pineal gland. And so what we've learned is we need to limit blue light the hours before sleep, 2 hours before sleep. So there's a couple different things that have been done now. One is making the recommendation is don't use the device 2 hours before you go to sleep. That's probably the easiest thing to do.
Sure.
But also if they wear glasses of any type, you can put blue blocking type of technology into the lens now that will eliminate the blue light that comes from the screen, which is what seems to affect that gland and the release of melatonin. So that is so if you have to use a device, particularly with my high school age and college age students, I'll put them all in blue blockers or blue blocking tints that are built into anti-reflective coatings to minimize that blue light, so it doesn't affect them as significantly and doesn't affect their sleep patterns. Because as we talked about, particularly with brain injury, once again, jumping back to that, brain injury, one of the biggest issues you have with brain injury is sleep pattern or deflection of sleep patterns as well. Mm-hmm. But we also see it in our high school students who are staying up to all hours of the night, and our college students staying up all hours of the night. So I think that's kind of what we really need to do. We really have to deal with this blue light issue.
Yes. So is it taking this anti-reflective coating with that blue blocker of approximately 10% effectiveness, or is it adding a tint? What did you call it? An FL150, an amber tint?
Well, FL41 I use for different purposes.
Okay, pardon me.
FL41 yes. I actually use it for significant photophobia, or for patients with migraine headaches, or a patient with what they call blepharospasm or lid twitching. It really works well in those situations. But FL41 is really actually even just a good general, a good tint to use just to decrease a lot of light sensitivity.
Okay. There is so much information and so many more questions, and we're going to make another list of questions for you, Dr. Shidlofsky, and I think we'll be tapping on your shoulder once again. So for people who are interested in learning more about neurodevelopmental optometry and all of the therapies that can be employed to improve vision and brain function, because now we know that they are one and the same, which website would you please direct them to?
Well, I think probably the one that's going to be most encompassing is the Neuro-Optometric Rehabilitation Association website. And the website is www.nora.cc. And I will tell you the website is being reconstructed right now, so in about a month it's going to be even more powerful. A website will have better graphics and things like that. So we're real excited about the redesign of that website. We'll also have a new URL coming out that you'll be able to use it, as well as the nora.cc. So those are some exciting things coming down the line for that website. But it even has a find a doctor list area on the website. So if you need to find a doctor in your area who does this type of care, you can locate someone.
And where can we find, and our listeners, find you online?
My website is neurovisionassociates.com.
And that would take us down to Plano, Texas, in the virtual world, and an airplane ticket otherwise.
that it will. And, certainly we're always welcome to take questions or make recommendations for people, referral recommendations for people as well.
Well, and that's so valuable when you've got a name you can trust coming from someone who clearly has been a pioneer in the field. That'd be you. It does mean so much. So on behalf of Cavin and myself, thank you for taking really your career and dedicating it to such novel therapies and such pioneering efforts, and really working to integrate other specialties and other specialists into this. It really, I'm going to come down and see that puzzle piece sculpture in your office, because that is the iconic representation of what we are here to do, to build, to create. So thank you for your time this morning, and we look forward to that Nora website and to speaking with you once again. Okay,
it was truly my pleasure. Remember, every day is an adventure. The Nora website is up right now, by the way. It's just being redone, so it'll be even more user-friendly. So just wanted to clarify that.
Thank you. Thank you for doing that. Have a wonderful day, and I wish you a terrific adventure with the next patient coming through your door.
Thank you so much, Charles. I'm really looking forward to working with you in the future, and we'll be in touch.
My pleasure.
All right.
Bye for now.
Take care. All right, guys, that's it. Thank you so much for joining us on this adventure in brain injury with Dr. Charles Shidlofsky. That was really fun, wasn't it, Michelle?
It was terrific, and I'm going to make certain that my son's friends and teachers are going to listen to that remark about three-dimensional and two-dimensional impacts on the brain.
Beautiful. If you'd like to hear other podcasts, you can find us on iTunes, Stitcher, Google Play, or anywhere else where podcasts can be found. You can find us on Adventures in Brain Injury or on feedabrain.com. And if you'd like to support us on Patreon, we would be so appreciative, just like $1 an episode. Head over to the Adventures in Brain Injury page and click on support and show your support there. As always, you can head over to our website or to iTunes and leave us a question or comment, and we read all of them. And head over to iTunes anyways. Give us a review. It really helps us rank up there and get this information to more people. And we look forward to seeing you next time.
Bye for now.
Bye.
Someone take me to a doctor.